We have Michelle Sugalski, I'm hoping I'm saying that right, is a licensed board certified genetic counselor at the Valley Hospital. She has been a genetic counselor for over 20 years and has been focusing on cancer genetics for the last 7. We're super excited to have her here today to speak with us.
Hi, I'm happy to be here. I am a genetic counselor here at Valley, and I work in Valley's Cancer Center, and I see people for hereditary cancer risk assessment. A lot of the patients that we see already have a cancer diagnosis, so they might be interested in understanding what their risk is to develop a second cancer, or they might be interested in undergoing genetic testing because results of genetic testing can sometimes have therapeutic implications. They might be interested in understanding what the risks are for other people in their family, their children, other relatives to develop cancer. We also see people who don't have cancer themselves, but they might come from a family where they think there's a lot of cancer and they want to understand what their individualized risk is for cancer. So today we're going to talk a little bit more about hereditary cancer risk assessment, the ways that we can assess risk. Sometimes it involves just looking at a family history. Sometimes it involves genetic testing. It rarely involves using a crystal ball. The first thing that I always like to remind people is that hereditary cancer is the exception and not the rule. Only 10% of cancers are hereditary. Most of the time, cancers just happen by chance. They're usually just sporadic or familial. There can be familial clustering, but really only rarely is the primary culprit for a cancer an actual gene mutation that's being passed around in the family. So basically, we're looking for zebras among horses. We're looking for the more unusual thing. And if we're talking about breast cancer specifically, only about 5 to 10% of breast cancers are driven by a specific mutation in a specific gene. There can be familial clustering, so being from a family where there's a lot of breast cancer can put you at an increased risk even if there is no gene mutation. But most of the time, it's just sporadic. These familial clusters that we see about 15 to 20% of the time, we think that those are caused by multifactorial issues. In our families, we share both our genes and our environment. So it's not unusual to share, lots of things can cluster in families, heart disease, diabetes, autoimmune diseases, because they can occur as a result of some combination of genetics and environmental influences working together. But the majority of our talk today is going to be focused on these more unusual situations where the cancer in the family is really hereditary. There can be some clues that can make us more suspicious that there is something hereditary going on. So when we see several relatives on the same side of the family with the same types of cancers or related cancers, for example, breast, ovarian, pancreas cancers, we can see those together with like the BRCA genes, or colon, uterine, and ovarian cancer. We can see those together with the Lynch genes. When we see cancers happening at an early age, that's a little bit more unusual. Usually in sporadic cancers, we'll see them develop as we get older. So if we see, breast cancer under 50, premenopausal breast cancer, that's a little bit of a red flag. Ovarian cancer and pancreatic cancer are just a little bit more unusual, and they tend to have a higher likelihood of being hereditary. So those are indications for genetic counseling and testing in and of themselves. Similarly, male breast cancer is a little bit more unusual and can be a little bit of a red flag for a hereditary issue. Aggressive prostate cancers, triple negative breast cancers happening in both breasts, or an individual that has had multiple primary cancers, or if any of these things in a close relative, if the individual, him or herself, has not had cancer, but has a close family history of these kinds of things. Of course, if there's an already identified mutation in a cancer predisposition gene, that's a very important reason to seek genetic counseling and testing. And certain ethnic groups just have mutations more commonly. For example, if you're Ashkenazi Jewish, the likelihood of having a BRCA mutation is higher. So if you have breast cancer, it doesn't matter how old you are. If you're Ashkenazi, you're a good candidate for it. So I mentioned a little bit, when we think about hereditary breast cancer, probably the first genes that we think about are the BRCA1 and 2 genes. And they get lumped together a lot, but they are two entirely distinct genes located on different chromosomes. BRCA1 is on chromosome 17 and BRCA2 is on chromosome 13. And I think they get lumped together a lot because they do have very similar risk, but they are actually different genes. We wouldn't expect somebody to have a mutation in both of them. That would be very unusual. And when we talk about having a BRCA gene, what we really mean to say is that we have a mutation within the gene, because every human being has two copies of BRCA1 and two copies of BRCA2. You get one from your mom and one from your dad. But when we talk about them, usually what we're referring to is an individual who has a mutation or a mistake in the genetic code for that gene. And a family history that has a BRCA mutation might look something like this. So when we see people for genetic counseling, we often draw out a family tree. And in our drawings, women are circles and men are squares. So in this family that looks to be hereditary, we see some of these red flags. We see ovarian cancer in the grandmother when she was 45. And then her daughter had breast cancer at 52. And then her daughter had breast cancer at 38. And then a cousin had breast cancer twice, first at 32 and again at 43. So again, these features that we see that indicate a suspicious family history are these breast and ovarian cancer together in a family, young age of diagnosis, multiple primary cancers, somebody having breast cancer more than once. These BRCA genes exhibit dominant inheritance. So if a mother has a gene mutation, it's 50-50 that she passes it to each of her children. So it's not always going to be if you have 4 kids, 2 are going to have it and 2 won't. It's flipping a coin each time. So in this example, you can see that half of them inherited this gene mutation in the red. The red allele is the one that has the mutation, and half of them got her other allele that has no mutation. And they also get half their genetic material from their father. So what are the risks associated with BRCA gene mutations? The biggest risk is for female breast cancer. So with BRCA1 and BRCA2, the risks for breast cancer are pretty similar in the range of 45 to 85%. The ovarian cancer risk is higher if you have a BRCA1 gene mutation versus a BRCA2 gene mutation. We can also see pancreas cancer in these families, especially with BRCA2, prostate cancer, melanoma, and male breast cancer. Another important feature is that BRCA gene mutations are also associated with an increased risk for a second breast cancer in someone who's already had breast cancer. So that's another important reason why people often with a new breast cancer diagnosis might consider genetic testing before their surgery. And we'll kind of get to that a little later. So why is it important to identify those people who are at increased risk for inherited cancer? It's important because there's things that we can do differently. There are different management recommendations for carriers for BRCA gene mutations. For example, with breast cancer risk, we recommend starting clinical exams at 25, breast awareness as early as 18. And then when you turn 25, we introduce MRI. We do that once a year until the age of 30, and then we alternate those with mammograms. So you never go more than 6 months without some kind of breast imaging. You'll do mammogram once a year and MRI once a year, and we scatter them. There's also the option of risk-reducing mastectomy and risk-reducing medications. Mastectomy is not mandatory for BRCA gene mutations, but it is an appropriate option. And men can have an elevated risk for breast cancer if they're found to be BRCA mutation carriers, so they can undergo clinical exams and sometimes even mammograms. Women who are carriers for BRCA gene mutations have an elevated risk for ovarian cancer. And unfortunately, we do not have effective screening for ovarian cancer. We can consider using a blood test called a CA-125, but it isn't really a very great or effective screening tool. So for women who are found to be at these significantly elevated risk for ovarian cancer, the recommendation is preventative removal of the ovaries and the fallopian tubes between the age of 35 and 40. Because BRCA2 mutation carriers have a slightly smaller risk for ovarian cancer, we think we might be able to delay that surgery to 40 to 45. It's important to talk about fertility planning because obviously taking out the ovaries, you can't have children once your ovaries are removed. And there is some evidence to suggest there could be a slightly elevated risk for uterine cancer, so it's appropriate to discuss the option of a complete hysterectomy. There's also a lot of research going on looking at removal of the fallopian tubes before the ovaries, because taking out the ovaries will put a premenopausal woman into abrupt menopause. And so for younger women, because we think most ovarian cancers actually originate in the fallopian tubes, we can consider the option of just taking out the fallopian tubes first and removing the ovaries later. But that is a very individualized discussion. Because there's an elevated risk for melanoma, we all really should be doing an annual dermatology evaluation, whether you have a BRCA mutation or not. And we're really starting to refine recommendations for screening for pancreatic cancer. We recommend screening for pancreatic cancer at age 50 for BRCA2 mutation carriers and for BRCA1 mutation carriers when there's also a family history of pancreas cancer. And screening for prostate cancer should occur in BRCA mutation in men who carry BRCA mutations beginning at 40. If you were to just pick someone off the street, not thinking about family history or personal history, the likelihood of carrying a BRCA mutation, the general population incidence is about 1 in 500. But if you're Ashkenazi Jewish, that figure is more like 1 in 40. So the threshold in who we should offer genetic testing to is lower in people who are of Ashkenazi ancestry. And this is because of 3 founder mutations that are within the 2 genes, 2 within BRCA1 and 1 within BRCA2. But when we do genetic testing, because even if you're of Ashkenazi, it's likely that you would carry one of these 3, but it's not for sure. So we still recommend a sequencing of the entire genes. So BRCA1 and 2 are not the only genes that are related to inherited breast cancer susceptibility. We know of many others, and here is a list of ones that would significantly elevate an individual's risk for breast cancer above that of the general population. So the average risk for breast cancer is about 1 in 8 or 12% by the age of 95. And this ATM, BARD1, BRIP1, CDH1, CHEK2, STK11, PALB2, BRCA1 and 2, TP53, and P10 is a list of these breast cancer genes, and it shows us what the lifetime risk is for breast cancer among female carriers. So you can see the BRCA genes, these ones on the lower end are the higher risk genes, and the ones up top are the lower risk genes, but all of them are greater than 20% risk for breast cancer, and that's a high enough risk to change our management. This is kind of another way to look at that, but this gives us information by age. So this lower axis is the age at breast cancer diagnosis, and the upper axis is the absolute risk. And you can see some of these, BRCA1 and 2 are associated with younger age and higher risk. But all of these genes that we listed before are associated with an increased risk over the general population. So many of these other genes also have guidelines for what to do if you are found to be a carrier. So if you have a risk for breast cancer, above the threshold of 20%, that's when we start talking about using MRIs in addition to mammograms to screen. The average person has, again, a risk for breast cancer around 12%. And we screen once a year using mammograms starting at 40. But if your lifetime risk for breast cancer exceeds 20%, that's when we start offering the option generally of using breast MRI in addition to mammogram. And here is a list of genes that would get you to a breast cancer risk of greater than 20%. In the middle column here, we have genes that have an even higher risk that we start considering the option of preventative surgery. It's high enough to warrant that discussion. And then in this final column, these are genes that also increase the risk for ovarian cancer to the threshold that we might consider preventative removal of the ovaries and the fallopian tubes. And these are based on standard NCCN guidelines. So anywhere you go, you would expect to get similar the same recommendations. These are professional guidelines, standardized. So genetic testing in the olden days, and when I say olden days, I mean like 10 or 15 years ago, really, when we were thinking about hereditary breast cancer, we were thinking only about BRCA1 and 2. But now we often are using a panel test to include all of those breast cancer genes. And then a lot of times when you're going through someone's family history, they have other types of cancers in the family. And the panel testing allows us to look at multiple cancer susceptibility genes all at the same time. And I really do like to think of it like a Venn diagram like this. It's not like one gene causes one type of cancer. This is the breast gene, that's the colon gene, that's the uterine gene. It's more like an overlap between the genes and the different cancer types. And the nice thing about panel testing is it allows us to look at multiple cancer susceptibility genes associated with multiple risks for different cancer types all at the same time. So genetic counseling is usually done before genetic testing or after you get the results for, there's pre-test and post-test genetic counseling. But in pre-test genetic counseling, what we're doing is we're assessing an individual's personal and family medical history, trying to get an idea of how they perceive their own risk and what is their motivation for testing, educating them on the basic genetics and inheritance, and cancer genetics and degree of risk associated with all of these genes. We review the risks, benefits, and limitations of testing, the actual procedure, which is usually just a blood test or a saliva test. Alternatives to testing. Sometimes there's other people that are more appropriate to test in the family. Sometimes, there's other alternatives. And then the options of what to do based on the assessment of risk and the potential results from the genetic testing. So genetic testing is really just involves blood test, or it can be done often from saliva and informed consent. And it's shipped off to a lab. There's a handful of genetics labs across the country that do a good job with the hereditary cancer testing. And they're usually using next generation sequencing and looking through these genes, reading through the sequence to look for mutations that are causing a problem with the protein function and impairing its normal job. And then we see these increased risk for cancers. For each of the genes that we're looking at, we'll get one of 3 possible results. If we find a mutation, obviously that means that there's an increased risk for cancer. So we review what we know is associated with that gene, the significant risks, the management of those risks, implications for care, implications for other family members. If it's all negative, that can mean different things depending on the scenario, but in general, it's less likely that there's an underlying inherited cancer susceptibility condition. A negative result can be different if you're testing an unaffected family member versus someone who's had cancer himself or herself. And we'll get to that in a minute. But lastly, sometimes we find what's called a variant of uncertain clinical significance. What a variant is it's a change in a gene that we're not sure if it actually causes a problem with how the protein functions. So if you use this example here, where we have the expected result of gray, Gray. A mutation might be replacing that A with an I. Now it doesn't sound the same. It's gree. And what does gree mean? It's not the expected result. It doesn't make any sense. No one would know what you were talking about if you said gree. So that's a mutation. It's not doing its regular job. It's not making sense. It's a problem. On the other hand, if we see Grey and we say it out loud, it sounds like gray. So it's not a problem. It sounds the same. Everyone would know what you were talking about if you read that word out loud. That's a benign change. A lab wouldn't even report that out. We all have genetic differences. And if we have these changes that we know cause no problem, they usually don't even get reported on a test result. What a variant is it's a genetic change that we just don't understand what it does to the protein function. The labs, you want to go to a lab that knows what they're doing, not only in their ability to detect a genetic change, but also in their understanding of how to interpret what that genetic change does to the protein. So labs will keep track of these variants, and if enough information is obtained over the course of time, the labs will reissue a report recategorizing the variant as either benign or disease associated. There's also a database called ClinVar, which is an NIH database, and most of the labs are working in consortium to update information as they get it, and work together to hopefully recategorize variants. We don't like variants; they're inconclusive, but most of the time when they do get recategorized, they get recategorized as being benign. So we don't generally make management changes based on the presence of a variant. We wouldn't test family members based on the presence of a variant, but hopefully in the future they would be recategorized with new information. Most of the people that I see are very concerned about their family members. So if most of the genes that we do find, they have dominant inheritance. So that means that first degree relatives of an individual with the mutation have a 50% chance of inheriting it. So if an individual is detected as having a BRCA mutation, they inherited it from either their mother or their father. So even the parents sometimes can benefit from what we call cascade testing. Children have a 50% chance of inheriting it, siblings also. Most of the inherited cancer genes, and there are a few exceptions, but by and large, most of them do not affect children. Like, for example, with BRCA gene mutations, we don't start MRI until you're 25. So there's no real medical reason to have genetic testing for children for these cancer predisposition genes. We like for individuals to be able to make their own choices about these kind of things. So testing of adults is appropriate and not really kids. Testing men, even for BRCA mutations, is entirely appropriate. It can change their management potentially, and they also can help other people in the family understand their own risk. All right, so this is an example of something that might come up in clinic, kind of a dilemma that comes up. So here is a patient who had breast cancer when she was 39. Her family history is important. Maybe this was done like many years ago, 20 years ago. And she had only BRCA1 and 2 testing back then. And the family history is such that the patient's mother had ovarian cancer and a grandmother had breast cancer at 45. So there's a significant family history. And we did genetic testing only for BRCA1 and 2, and it was normal. So what do we do now? There are some questions here. Does she need additional testing? What is her risk for a second cancer? Does she have a hereditary predisposition, even though she's had normal genetic testing? How would we manage her risk for a second breast cancer? How would we manage her risk for ovarian cancer, given the family history of ovarian cancer? How would she talk to her family. What are the risks for her kids? Are there other genetic factors that could be causing her cancer? Um, so I don't have all of the answers to these questions, but I think in today, in 2025, we would do more than just testing for BRCA1 and 2. We would probably offer this patient an updated panel to evaluate some of those other genes that we know that can present quite similarly in a family or in an individual to see if maybe she has a PALB2 mutation or some other inherited cancer gene. But sometimes they're even after panel testing, families like that come back with normal results, and we're still faced with a lot of these questions. And a lot of times these families look to be hereditary, but we haven't quite figured it out. Could there be a gene that a gene mutation that the lab just doesn't have the ability to pick up? Could there be another gene that hasn't yet been described? We don't really know. Here's another thing that comes up quite often for me. Um, this arrow is pointing to the person who comes to see us in clinic. And she comes from a strong family history. Again, the multiple young breast cancers and ovarian cancer. But maybe she doesn't know if anyone in her family has had genetic testing and she wants testing for herself. Um, you know, in this situation, we really encourage people to see if someone in their family has had genetic testing, because the way that we interpret her result would be very different depending on the result from the other people in the family. If a mutation has already been identified in the family, her risk for inheriting that mutation is now 50%. We think that, let's say the sister and the mother have a BRCA mutation. Her risk is 50%. She either has it or she doesn't. If she has it, then we talk about all the things that we talk about for female BRCA mutation carriers. If she's negative, her risk is general population risk because we know what's causing the breast cancer and ovarian cancer in the family, and she doesn't have it. However, if these people who have had cancer in the family did have genetic testing and they've had a panel and it's all normal, we weren't able to find the cause of this inherited cancer susceptibility, genetic testing for her is not really going to be informative. We might give her a false sense of reassurance with a normal result. Look, all these people had normal genetic testing, but they still developed these early onset cancers. Her normal genetic testing is not really all that reassuring in that scenario. So a normal test result can have a different implication depending on, the family history context. Sometimes there are these strong family histories of cancer that we don't find a gene mutation. And individuals might still be at higher risk for breast cancer because they have this strong family history. Tyrer-Cuzick is a model that we can use to evaluate lifetime risk for breast cancer. I usually do this after genetic testing has come back normal, but there might be other factors that can elevate risk. Tyrer-Cuzick uses several different factors that we know are related to breast cancer risk, like hormone factors. It uses the age at menarche, the menopausal status, the age of first delivery, how many pregnancies you've had, if you've used hormone replacement therapy, and body mass index. They also consider family history and other factors like breast density or if you've had breast biopsies before. And they take all these risk figures and they do some fancy math and they compute a lifetime risk for breast cancer based on that information. And if the threshold exceeds 20%, and remember that 20% figure holds true with some of those genes, to consider the option of using MRIs in addition to mammograms. So finding a gene mutation is not the only way that we sometimes consider using high risk screening. Um, there's also something called a polygenic risk score, which some of the labs are doing, where in addition to looking at these high risk breast genes with significant penetrance like BRCA1 and 2, PALB2, some of the ones that we listed earlier, they're looking at single nucleotide polymorphisms, or SNPs, that we know have individually have very minimal risk for breast cancer, but together might elevate an individual's risk. They don't have a lot of data in some. They have more data in people of Caucasian European ancestry, so it's a little tricky to use a polygenic risk score, but it's something that might potentially modify risk. So those, again, with a lifetime risk of breast cancer greater than 20% are typically recommended to undergo high-risk screening, which usually involves an annual MRI and an annual mammogram on a 6-6 protocol, so that you never go more than 6 months without some kind of imaging. And usually the screening, we say, to begin at age 40 or 10 years younger than the earliest diagnosis. So can begin as mammography can begin as early as 30, and MRI even younger, as early as 25. I wanted to shed light on a term called previvor, because I just think that it's, it's Breast Cancer Awareness Month, and we talk a lot about cancer survivors and breast cancer, awareness. But what a previvor is it's an individual who has a higher risk for cancer, usually because of a genetic mutation that puts them at elevated risk. And there's kind of a unique set of concerns that go along with being a previvor, and you might not fall into the category of being a breast cancer survivor, but you're still kind of dealing with a lot of stuff. And I just wanted to kind of shed light on the unique set of circumstances and issues that previvors are facing. And some common concerns include ongoing uncertainty, fears that cancer is already there and we just haven't discovered it, or that you're damaged in some way. There can be body issues. Thinking about your elevated risk for breast cancer might make you feel differently about your breasts, or how your body or sex life might change after you undergo preventative treatments. You might worry about how to tell family members who might also face this elevated risk. There's definitely feelings of guilt that come up. Um, Parents worried about passing on gene mutations to their children, even though I think that they know in their mind that they have no control over this. I don't think you can help but feel some guilt sometimes. And it may be surprising, but a lot of people, I'll see a lot of family members, multiple members of the same family with a gene mutation. And sometimes sisters will be tested together because a mother or a father carries a BRCA gene mutation. And you think that the one, let's say one inherits the mutation and the other doesn't. You think that the one that inherits the mutation is the one that's going to have the tougher time, but sometimes it's the one that tests negative that really is feeling pretty bad for their sister going through all of this, and we call that survivor's guilt, and it's real. There can be concerns about insurance discrimination, life insurance, disability insurance, and actually just the cost of medical care. All of these screening and prevention things that come up can be very expensive. I also just wanted to touch on this idea of insurance discrimination. There is a law in place called the GENE Act, which stands for the Genetic Information Non-Discrimination Act. And what GINA does is it says that your health insurance company is not allowed to call your genetic information a pre-existing condition. It can't say, like, you were born with this gene mutation. It was present, at birth, and it's pre-existing. We're going to drop you. But GINA, unfortunately, does not apply to life insurance or disability insurance. And this especially comes up for young, maybe a child of someone who was diagnosed with a BRCA mutation after she was diagnosed with breast cancer, and now she's got, a 20-year-old daughter who has no other health problems but wants to be tested. So sometimes people consider getting life insurance before they have their genetic testing, because it can be more difficult to get if you are found to have an inherited susceptibility to cancer. So the whole point of the genetic testing process is to help people make better, more targeted healthcare decisions, and we don't want to inadvertently hurt them in the process. And that's the end of my talk. I think it's as Thanksgiving is coming up, it's the fall. It's a good time to kind of discuss family history, cancer. Sometimes people are private about this stuff, and I think the more you know about what's going on in your family history, the more you can understand what your risk is and take the appropriate next steps. Thank you.
It was a great presentation. At this time, I'll give people maybe about 30 seconds to a minute if they do have any questions. Righty, I don't think anybody has any questions. Again, thank you so much. That was a great presentation, very informative. I hope everyone has a great evening. And don't forget to fill out our survey to provide feedback for this presentation. Thank you so much. That was great.
Thank you.
Yep. Have a good night.